Good evening, everybody. I would like to welcome each one of you to BIC 2021 Best Interventional Cases. So the second session of BIC is the road less traveled, chronic total occlusion. And we have with us Dr. Anand Gnanaraj as our moderator for today's session. Dr. Anand do not need an introduction as such, but I would still like to say a few words about him. Dr. Anand is a complex CTO operator in Apollo Hospitals, Vanagram. He also runs CTO Center of Excellence, which focuses on training young IVCs in CTO techniques. So no other doctor better than him to moderate this session. Dr. Anand, please take over the session, sir.
Thank you, Bhamri, for the wonderful session that you have organized, and we are really happy to have such elite panel, chair people and presenters with an international faculty for this excellent meeting. I would like to welcome Dr. Ravi Mehta, Director of Department of Cardiology, and with a huge amount of experience, and all of us know him as a mentor for interventional cardiology sessions. Also, Dr. Duggal, who's HOD and Senior Interventional Cardiologist in Jahangir Hospital. Dr. Prathap Kumar, a well-known person when it comes to CTO procedures. He's the chairman of Mehta Group of Hospitals. And of course, our international faculty, Dr. Rathore, who has been with us for multiple sessions and whose inputs have great value, especially in the Indian scenario. And he's a consultant in NHS in the Firmly Park Hospital in the UK. And we also have panelists, Dr. Rajpal Singh, Dr. Asadullah, Dr. Gagan, Dr. Naveen, Dr. Prasant, and Dr. Rajesh, and Dr. Ravi Gupta, and a few presenters whom I will introduce when the time comes. Without delaying much, we will go to the first session, Complex Post-CABG ISR CTO PCI, presented by Dr. Kapardhi. Dr. Kapardhi, can you please share your screen? Dr. Kapardhi is a Senior Interventional Cardiologist in Care Hospital, Hyderabad. Dr. Kapardhi, please take over this.
Am I visible and audible?
Yes, you are.
Hello.
Yes, you are. Please go ahead.
So today I'm presenting an interesting case of post-CABG instant restenosis CTO of LAD. How I encountered some of the issues and how I overcome. So the clinical history is as follows: a 67 years old gentleman having diabetes and hypertension risk factors. He had old interval MI in 1999 September. He underwent angioplasty to LAD at that period. Then subsequently he is asymptomatic and he had exertional angina in 2005 May. And at that time, instant restenosis LAD was found. And he underwent Lima to LAD during that period. And then subsequently he's asymptomatic. And recently he presented with a recurrent chest angina in 2020 October with STT changes in V1 to V4 leads. And he had a mild LV dysfunction with ejection fraction of 45%. And his angiogram revealed occluded Lima and instantaneous ISR LAD mid-segment CTO with some ipsilateral faint non-interventional collaterals from circumflex. And RCA is normal and dominant. And index lesion of angioplasty is ISR instant restenosis LAD CTO. So this is the baseline angiogram. You can observe a non-dominant circumflex. And left main and LAD is okay. But after the major diagonal, the LAD was it was shrunken and totally occluded with a ISR CTO and faint filling of the distal LAD you can observe. And then right coronary is a dominant and almost it is normal. It was stuck 1 minute, it was stuck actually. Again, I'm sharing actually, it was stuck actually. Can you see now? Hello? Hello?
Yes, we can. Oh, yeah, gone again.
1 minute. I am sharing again. Yeah. Suddenly some disturbance came. Sorry.
Dr. Kapardhi, it's visible now.
Yes, madam. Yeah. I'm going now. So after this, as the CTO, the JCTO score is 2. Then we followed, and CTO segment is also around 24 millimeters. The primary strategy is anti-grade wire escalation, de-escalation strategy. So with the help of the 7 French extra backup catheter and Caravel micro catheter help support, as I know, it is a very long-standing occlusion, even prior to CABG. I have taken directly a Gaia second wire with the help of the Caravel microcatheter support and directed towards the CTO segment. And I crossed the proximal segment, and it is almost the Gaia second. It traveled the CTO segment and successfully penetrated the distal cap. Then slowly, I have seen that after confirming that Gaia second is in the distal true lumen, then I want to advance the Caravel catheter. Then some difficulty I found. Then suddenly, when I retract the Caravel, some unidentified opacity I found on the Gaia wire. I thought any broken tip of the Caravel micro catheter tip. What I did is, yes, slowly I withdrawn, but still it is persisting. And I have checked the tip of the micro catheter. Then it was totally intact tip of the micro catheter. Then what I did is, I took the lowest profile balloon, that is a Nick Nano balloon, which is 0.8 millimeters, with the help of guide Jilla. Then I advancing at the find difficulty in passing the these smallest low profile balloon. Then I found something is different of wire based issues. Then I want to remove the wire. That is most important. Then I advanced the guide Jilla till the proximal cap. I advanced it. Then I removed it as an assembly, entire segment. Then in vitro testing, you can see that the radio opaque portion, it is becomes crumpled. Actually, if you say it is a composite coat technology, what happened is once a Gaia second I am trying to pass, what happened, it becomes crumpled and produced unidentified opacity. And then subsequently I repeated the steps, took the Caravel and another Gaia second. Then I ultimately successfully crossed, and I parked in the distal. Then I removed this one, and subsequently check injection, what I did is it was in the false lumen when I exchanged with a workhorse wire. Then what I did is I again removed that wire with the help of the micro catheter. I took the pilot 50 after removing that workhorse wire. I took the pilot 50 with a Caravel and then redirected towards the true lumen exactly here in this level. Subsequently, I successfully redirected towards the true lumen, and then my job made easy. I pre-dilated with 1 mm balloon, and gradedly with the 2 mm balloon also I dilated with the help of guide Jilla, advancing to the proximal cap of the CTO segment, and then 2.5 mm balloon pre-dilated, and good lesion preparation. Then after check injection, this is the one after adequate lesion preparation. Then I took 2.5 to 38 mm Duggal stent positioning across the diagonal from LAD and into the distal LAD, from proximal LAD to distal LAD, and then deployed. After deployment, I post dilated with the 2.7 to 10 mm NC balloon, And I got, this is a very good result with a TIMI 3 flow. And this is the TIMI 3 flow I got. So this is the my take-home message. So a post-bypass surgery, instant CTO is a challenging subject, and because it's a long duration CTO, the fibro and insignificant calcium will be there inside that stent. And the issues in this present case are, one is a damaged hardware, that is a Gaia wire, which becomes crumpled and produce unexplained opacity, thinking that it's a broken micro catheter, but it's not the thing. And it is a fatigued wire with a crumpled composite core. And then second important is deflection of wire to the subintima at the anastomotic site. Most important. So these issues are addressed by extraction of the damaged wire with the help of Guidezilla, NMAS, everything with the help of the Guidezilla I took, because it is not supporting even 1 mm balloon or 0.8 mm also not passing across that damaged wire. And then wire de-escalation by means of hydrophilic, that is pilot 50, because already the pathway was already formed by means of these Gaia wire, and then redirected towards a lumen, that is a guide wire based re-entry, even though first it went into false lumen. So unexplained opacities on the guide wire can be due to broken tip of the microcatheter or crumpled coating of the guide wire. So necessary hardware should be there on the shelf before planning angioplasty, so that we can overcome these type of issues which may prolong the procedure, or sometimes it may interrupt our procedure also. Thank you.
Dr. Kapardhi, thank you for the lovely case and very challenging situation. I think, this is a problem with the Gaia group of wires. They are meant to transmit 1:1 torque. And if the tip is embedded in some fibrotic tissue or calcium, then and you continue to torque the wire, it gets bundled up in a particular spot. And usually it is the transition zone between the radio opaque part and this. And it is a real challenge to retrieve such wires. Usually it starts getting uncoiled and it becomes a complete mess. It's good that you took the Guidezilla and got it out. Thank you for the excellent case. And I think instead of me presenting the next case, we will go to Dr. Samirr Kubba. He has some personal commitments that he wants to go a bit early. So we will take a case from Dr. Samirr first. Dr. Samirr Kubba is an Associate Director of Clinical Interventional Cardiology in Max Hospital, Vaishali.
Anand, actually, we don't have any discussion about these cases.
Oh, sorry. Okay.
I think you discussed that I am talking.
Yeah. I completely messed it.
Sudheer is
sorry. Chairpersons and panelists, please.
See, Dr. Ashish Mehta is Sar is sitting and Sudheer is sitting.
I know. No. Pankuri called me and said he has to go early, so like that was in my head.
Actually, an emergency has just come, and I'm so sorry. So
no problem. But actually, we should have some discussion about the case and minimum 2 minutes. And
yes, please.
See, actually, I have Ashish Mehta sir is actually then sir after sir I can tell any.
Yeah, sir.
Sir is
Prathap. No, Prathap, you go ahead.
Sir, actually, okay, sir. My question to Kapardhi is actually Kapardhi. You actually. This was actually an ISR CTO. Proximal to the ISR CTO, the wire was broken or wire was actually having a problem. Proximal to the ISR CTO or just inside the CTO? This I did not understand.
In the CTO only. Once actually withdrawn the microcatheter, then I observed this abnormality. It was masked by microcatheter.
Like
and I want to exchange.
Correct. Like Anand told, the Gaia has these problems, but you actually... It is not the problem of the Gaia. Is it the problem of the operator or the Gaia? Because if it is the problem of the Gaia, then why did you take the second time also to cross the CTO by the Gaia?
The thing is, any long-standing high-resistant lesions, definitely, I found this is
that is the only point I want to discuss. That is actually
yeah.
one of the point I just wanted to stress. ISR CTO post of that they did a CABG. Then the patient is coming extended. The patient went for a CABG, then came back. Actually, this message should be given to all the participants that in an ISR, it is a long-standing CTO. Gaya is not the wire of choice. Sometimes Gaya will be a way for the people like Kapardhi, but this is not the wire of choice for CTO. This is what is the comment I just wanted to make. I just pass on to our sir. Sir, Mehta sir, please, sir.
But Prathap, I'm asking you a question. Why would you be opposed to Gaya 2? Gaya 2, I'm just saying that it's 0.011.
Yes,
the steep load is about 3.5.
Correct, sir.
It's a very highly torqueable. You are within the stand boundaries. So that is one
Sir,
which gives
actually,
you
my point is
boundaries.
sir, my point is very severely fibrotic calcified lesion. This is not the wire of choice. It can be get stuck inside and can be broken. In the such type of wires, actually, you should actually go for a higher wires like Miracle 6 or something like that. Then you can, the crossability will be much easier. After that, you have to de-escalate the wire to any level and then finish the procedure.
But Gaya 2 crossed.
Gaya to cross, sir. Actually, I'm just telling that is a problem. After crossing, this actually torqueability, actually, it is a pushable wire. It is not a highly torqueable wire. You just actually, the wire can get entangled inside the CTO segment. That is actually what the problem happened, especially with the caravel. Caravel is also not like fine cross. It is a very soft microcatheter. It can also get entangled in the severely fibrotic lesion. Caravel is a good wire for if you wanted to do a CTO in a septal channel or a epicardial channel, definitely Caravel is an excellent microcatheter. In a severely calcified or a fibrotic, severe fibrotic, Amjad will be long duration CTO. He actually opened up. That is what I'm telling. With the due respect to the skills, I'm just telling about the wire selection. That is what I'm telling.
But I believe as far as the crossboss is concerned, instant CTO is one of the best devices to use. And in the Asian algorithm, it is mentioned as the first choice. Anybody experience in instant CTO with the crossboss?
Yeah, Sudheer?
Yes, sorry, yes. Yeah, it is included in the algorithm, and it is a good device. I think it all depends. So once you penetrate the proximal cap, I think the proximal cap is the most important place. Once you penetrate the proximal cap and then you exchange it to a crossboss, it may work well, and sometimes it's difficulty. Now, coming back to what Prathap was saying, this wire, this was seen very commonly. It is due to the over torque of the wire, of first generation wire.
Yeah.
So it has one-to-one transmission, and then people say, like standard teaching, you should not rotate more than 180 degree, and it is a deflection. So you have to deflect the tip, and if the tip is not deflecting, it is stuck in somewhere, then all the torque goes to the proximal part of the wire rather than the tip. And this gets that entangled, and it was seen very commonly this first generation, and some of this is overcome by Gaya Next series of wire, which is a slight improvement on, I think this must be a older generation Gaya.
We are unlucky, Sudheer. We never got Gaya Next.
So I think yes, I'm aware of, in the interest of time, maybe we can move on and then keep discussion in between, like some common themes.
Okay.
Yeah.
Next case then.
So we can move on to the next presenter, Dr. Samirr Kubba. Can you please take over the screen and start your presentation?
Sorry, Anand. Actually, for discussion, I just brought it.
Not at all. I completely forgot. I was so focused on getting him online. I completely forgot about the discussion. Anyway,
I'm very thankful to all of you, and I'm so sorry that it's because of me that things have got slightly odd. Are my slides visible, sir?
Not yet.
Yes, visible.
Yes, we can see your slides.
Okay.
Yeah, we can see.
Yeah, so this is not very exotic, but this is something I faced a challenging situation while working in a relatively smaller center, peripheral center, where you are resource challenged. And this was actually an acute inferior wall MI with a complete heart block who had come to us. And the thought was to do a primary angioplasty for him. And this was his ECG showing a complete AV dissociation and inferior wall MI. The pulse was 40, BP was okay, TWAP was positive, and he had a regional wall in the RC as expected with a LV of around 45%. So we paced him and then took him up for an angio, thinking that it is a straightforward, most likely the RCA, because he has a heart block, and the ST suggested that. So this is the angiogram, which actually showed a left system wherein the LAD was by and large okay, but he had a significant disease in the ramus and the circumflex and some other branches which were fair sized. There was a retrograde filling of the right coronary artery, as you can see on the right panel. That is the iliocaudal view, actually, to look at the other critical lesions. And then finally, that was the RCA, which we thought was the culprit and occluded 100%. And we thought it would be a easy job, and I was the solo operator over there in a resource challenge setting, as I told you. So the thought was to take a BMW wire, and I took it initially. It would not cross. There was some resistance. Then I escalated to a whisper, used a balloon support, but somehow or the other things were challenging, and the whisper also could not cross. And the feeling of the lesion was something like a chronic total occlusion. In the process, what happened was the RV branch, which was initially flowing, also closed off, and the patient started to have angina with some hypotension. Inotropes were instituted, but then he was able to tolerate the procedure slightly more. So what we thought is it was a small center. Should I abandon the procedure, send him to CABG, which I thought was not a very good option, escalation of the wire, and I did not have other stuff with me. And obviously, whenever you're dealing with a CTO, you must have, but most of the times you're dealing with a CTO in an elective setting, and this was an emergency situation wherein the culprit was actually a CTO. So we had a fielder with us, and with some persistence and patience, and it was difficult, especially to penetrate the distal cap. And with about 10 to 15 minutes, because the artery was closing off, we could cross the lesion finally, and then penetrate the distal cap, and then the procedure was relatively okay. And that was a pre-dilatation with smaller balloons, and finally the lesion was stented. Now, what happened after this was the patient actually, that was the stent placement, and that was the inflation of the stent. And that was the final result, a pretty decent result, some lesion in the mid-RCA, which obviously we... And now the patient continued to have this heart block even for next 2-3 days, and this was after switching off the TPI, and it took us 7 days actually for his heart block to actually disappear, and we had to discharge him on a first-degree AV block, and he is doing fine after that. The other culprits have not been tackled. This is around 3-4 years back, and the issues, I believe it was not very exotic as far as the case of CTO is concerned, but the issues are usually we deal with a CTO in a stable setting, and uncommonly we do find sometimes a CTO as the culprit artery during STEMI, but most commonly what happens is that you have a culprit artery and you have an associated CTO in some percentage of cases. But the problem is when you have a CTO as the acute culprit artery, the cases become more challenging because the patients will have associated hemodynamic and electrical instability. There's always an associated thrombus burden, and at times even minimal sort of a meddling with the artery can push that thrombus and actually block everything which was initially available, or the microchannels, and inadequate morphologic assessment of the vessel may actually make things even more complicated. Now, the possible mechanism of a CTO causing STEMI is that there's a plaque rupture proximal to the site of CTO, giving rise to a thrombotic total occlusion of the vessel, and also its antegrade collaterals and microchannels leading to a STEMI. Obviously, the implications are a lower success rate, more procedural time, and possibly more complications, and at times you're not able to be successful. This is a paper which I found from an Indian colleague in Nagpur who presented this in 2013 ACC, published in the American Journal of Cardiology, wherein he looked at the primary PCI in his center in Nagpur, and he looked at 180 STEMI patients who had presented between this time duration. And the criteria for acute on CTO were the following, which we all know. But what he found was that it was about 14% of the patients who had a CTO as the culprit artery in that 1 year. So it's not that low also, and we all have seen this kind of a situation. But when you are in a resource challenge setting and you don't expect the culprit to be a CTO, you can have problems. The infarct-related artery was about 70% of cases the right coronary, which was the situation in our patients, followed by 20% LAD and LCX about 10%. The success rate of primary PCI was about 18%, and patient had to be referred for emergent CABG in about 15% of the cases, and about 5% the PCI of the donor artery was done. Sometimes these patients can present with cardiogenic shock, which was the situation in about 30% of his cases in his series. Complete heart block was about in 14%, which was the situation in our patient also. And the typical clinical presentation of these patients is that they have ECG suggestive of a STEMI, but the angiographic findings favor a chronic total occlusion. But in my case, it was 100% occlusion, and I thought, although the occlusion was blunt, and retrospectively I realized it could have been a CTO, but I did not expect it prospectively. And when I took a detailed history from this patient, he was having effort symptoms for about 15-20 days. And in his series, which I just quoted from Dr. Hore from Nagpur, 75% of them also had history of effort symptoms. So not very exotic as far as the case, I would say, is concerned, but possibly the setting in acute coronary syndrome and an acute STEMI, sometimes we can face these problems, and especially where you don't have proper hardware, you can have challenges. Thank you so much.
Thank you, Dr. Samirr, for the lovely case. I have also faced a few of these cases, but pathophysiologically, it doesn't make sense for a CTO to present as an ACS. So probably, there was a 99.5% lesion, which thrombosed and caused a total occlusion. And when we try to wire it, we are not able to find that small channel, and we end up making it into a CTO PCI. This is the only thing I have always explained it to myself. I would like to hear from the chairpersons about this, Dr. Mehta.
So you're on mute, sir.
Anand.
Yes, sir.
There are a lot of unusual things. They're not easily palatable to me. First of all, the definition of CTO is that TIMI zero flow for more than 3 months. And if that is the situation, then I think the viabilities and sustainability of the myocardium is completely based on ipsilateral or contralateral collaterals. I don't see them here. So the first question is there a viability? Is this the culprit artery? In other words, probably it was not a CTO, but it was a very tight occlusion, which probably was little firm, and that probably due to a gradually layering of plaque over a period of time, plaque over the plaque over the plaque, and ultimately, in contrast to an acute occlusion that you get in STEMI, where 40% plaque becomes 100% in matter of few minutes or few hours, this is not a situation. And I think in a case like that, the very fact that the operator chose to use the wires like Fielder FC and BMW and all those things, I think that it defies the principle of a CTO, where I think this kind of workhorse wires are not expected to cross at all. And I think if at all he had the support of a contralateral collaterals supplying the distal segment, then he should make an effort that he must know where is he going. That I think you need a contralateral injection in that situation. I can understand that you want to call this a PAMI and associated a 90 or 95% tight lesion and the final 5% occlusion by a thrombus. That I think is a possible situation. That's my interpretation. You can't call a CTO an acute occlusion of a CTO. CTO means zero, TIMI zero flow. That's it. What do you say, Sudheer?
Yeah, I think I kind of agree. Actually, with definition, this is an acute MI, and it is not a CTO. And what happens is it also depends on if the patient has a delayed presentation of MI. Many times we see similar situation when your workhorse wire will not sail through. Then you might have to use like pilot 50 or some kind of hydrophilic wire to cross the remaining channel. And it could be acute on chronic, but I think it may be behaving like CTO, but we shouldn't call it a CTO. And if you look at large series of CTO PCI, like retrospective series, about 8 to 10% of CTO patient presents as acute coronary syndrome. But they have not mentioned that patients in CTO series presenting with ST elevation MI. So acute coronary, most of them are non-STEMI and obviously that kind of situation. So yeah.
So with all due respect, I would just like to make a few comments here. This patient had a retrograde filling of the RCA, and the RCA was 100% bluntly occluded. And in fact, to me also, it would have been a straightforward, simple case. But I faced these problems, and it was specifically only after the Fielder XT and then FC with balloon support. I didn't have a microcatheter, and I could feel that kind of a situation. Obviously, it was an acute on CTO. It was not a CTO technically, if you look into semantics, but it was not the kind of unusual case. And when I went and searched through literature, most of the data which I got was CTO as a non-culprit artery in ACS causing problems. But CTO as the culprit artery, there were anecdotal reports. And that is why I mentioned this data from our Indian colleague at Nagpur, who presented this at the ACC in 2013 way back. And he postulated these mechanisms. And that is the reason I thought to share it, because this is something which I can learn from esteemed colleagues over here. That at times, and now we are facing it more commonly, we have these kind of tough lesions. But this was around 3-4 years back, and I was alone in a peripheral center. And thankfully, I had a Fielder wire there with me, and it actually helped me out.
But that was Fielder FC.
Yeah, sir, I started.
That wire was Fielder FC.
So I started with an XT. I started with an XT, sir. The XT could cross the proximal part or something, but when it came to the distal cap, it was just not going. And the RV branch also started to get occluded. So I did not show that in the cine, but then I took a Fielder FC, and thankfully, by God's grace, I was able to cross, and it was a lot of a difficulty even crossing that 1.5 millimeter balloon. So probably by the time the patient had come, it was 100% occlusion. But the way it was behaving could have been something like a very high-grade stenosis, as we are all discussing, an acute thrombus causing that, maybe a resistant thrombus, and then I was facing the resistance because of that. So my only aim to present here was the way the heart block was there, the complete heart block was there, the left system was relatively flowing okay, except for some 90% stenosis in the ramus. One point of time, I thought maybe the culprit is somewhere in the left system. Then I sat down with myself that even if I open the left system, the heart block is not going to disappear, and the right coronary was distally filling. So I thought RCA should be a cakewalk, but it was not. And usually I have never faced this kind of a situation in the past. Obviously, my experience is much more limited than yours, but this is something which I thought that I'll share and get opinions.
Samirr, actually, I just wanted to tell my point. Actually, what you are telling may be correct. At the same time, the 15% of the cases of acute MI in a setup is CTO means unbelievable data. That is number one. Number two, in a STEMI situation, it is impossible to have this. Non-culprit vessel CTO is definitely documented because it is there. Number two, what you are telling is actually, as Sir and Sudheer told, basically this cannot be considered as a CTO, but even then, in an acute MI situation, there is one more possibility is that your first wire goes subintimal and create a problem. Then the second wire coming to the subintimal to intima definitely will be a challenge. And that situation is one situation produced by people, and they may think that it is an CTO. In that situation, your balloon crossability and all will be a problem. You are luckily crossed with Fielder FC. That is actually one possibility. That is what I am thinking, in addition to the thinking of Sir and Sudheer.
Yes, sir. I think I used a whisper wire, and I think I could have caused a mess with that. So I completely agree on to that. It could have happened. But again, the kind of feeling on the lesion was not the straightforward acute MI feeling which you have.
Samirr, I have
like that, Samirr.
This patient, you proposed a mechanism wherein you have collaterals, and then the collaterals, ipsilateral collaterals, proximal to the occlusion, getting thrombus, occlusion, causing a STEMI. Theoretically, I think it's probably you can take it.
Well, I'll tell you what, Sudheer and Prathap, my take is like that if there is a CTO and there is a viability created by the collaterals, either ipsilateral or contralateral, if there is a single major dominant collateral, which you would otherwise contraindicate to use as a retrograde channel, that kind of a collateral, on which the entire distal circulation is dependent. When that goes on strike, maybe due to profound hypoperfusion, maybe due to thrombosis, then the infarct would take place in that territory. Otherwise not. And not only that, no matter what you do, if you have a slightest suspicion that you are dealing that kind of a situation, which was a chronic total occlusion and the collaterals went on strike, because for whatever reason, I think it may be safer and good to know where you are going, so that geographical mapping from contralateral injections will be helpful. Samirr, you did a good job, all right, but we are discussing large, suppose in case anyone out of audience or ourselves, etc., faced with a situation like that, what are the things and possibilities that we should keep in mind so as to achieve a higher success rate without any problems? Or we can move on to Anand.
Anand. Thank you for all your lovely inputs, and thank you, Dr. Samirr, for sparing the time during your crisis.
Mr. Thank you to all of you for allowing me to present it. I have an emergency, so I'm so sorry, and I just thought I'll learn from all the esteemed people here, sir. Thank you so much, sir. Thank you.
Please unshare your screen so that the next presenter can move on.
Who is the next presenter? Anand, you are the presenter? Or?
I am the next presenter.
Okay.
So, can you see my screen?
Yes. Yes, just go ahead.
All right. Okay. So, in continuation of the previous case, this is not a similar situation, but a similar clinical scenario. So this patient is a young 33-year-old male, heavy smoker, and brother of one of our anesthetists in our hospital, present with inferior MI and of at least 2 days duration, because they had not diagnosed it because he was having vomiting and some vague symptoms. And on the 3rd day, they took an ECG and found some STD changes. So he still had some discomfort, and echo showed adequate LV function with some inferior wall hypokinesia. And he was absolutely asymptomatic before this. This was the first angiogram. The left was normal. And I thought the circumflex is a non-dominant small vessel with some occlusion. And this was the right. So initially, it was a little bit careless of me to assume that it must have been the right. It's just that clinically, I thought it was the right, and I just took it up. And I had gone radially, and in 2 minutes, I realized that this is not the ACS, and just reviewed the left. And in fact, actually, the left was a very big circumflex, fleshly occluded at the ostium with thrombus. RCA was a long-standing CTO. You can see it filling nicely with collaterals. And first I wired the circumflex, and I was not sure what to do beyond this point because the thrombus was just sitting at the ostium, and if I balloon it, it's going to prolapse into LAD, and we are going to lose the patient on the table. So because that was the single surviving artery. So you can see how the wire cuts through the thrombus because I was still trying to figure out whether this is really thrombus or something else. So I tried wiring with another wire. You can see how the wire cut through the thrombus. So I left it there. So the dilemma was whether to treat it as the PCI or just sit on it for some more time. Anyway, he was beyond the window period. So I stopped the procedure, and I was not mentally prepared for a CTO PCI. Neither were the attenders, neither was the patient. We had not checked his creatinine, nothing. So he was just taken up as primary. And then I had a long discussion with the relatives and treated him with low molecular weight heparin for 3 days, hoping that the thrombus would resolve. And took him up again, this time bilateral femoral. You can see that the thrombus is still sitting there in the same way, and nothing had changed. So I decided to do the right first, so that we have an open artery on both sides in case there is a thrombus migration. So the right, I went straight to retrograde. I decided go antegrade because there was nothing to really direct the wire. Retrograde had a lot of, though it looked like there were so many nice channels, each channel had its own problem. And I had to go through multiple channels and finally get, you can see that and it looked like a very clean channel, but it was nowhere near PDA. Then finally, we took a microcatheter injection and that showed a decent channel. And again, this wire went through that, but it was nowhere near PDA. Then you can see that finally, after a long time, I found this injection, and at this point, we were able to identify this channel that was going towards PDA very clearly. And so finally, I managed to get into PDA and RCA. And you can see that it was a clean crux. This was I had to switch over to a stiffer wire. And this was Miracle 6 to drive back through the RCA. It was a really, really tough lesion, even in the distal segment. And with some difficulty, I managed to reach up to the proximal RCA. But from there on, again, it was a very big challenge to get into the guide because there was a chunk of calcium sitting there. And because the RCA was like conically taped, we're not really getting into the lumen of RCA. You can see the wire slipping into the side. And though the guide was sitting actually end on into the entire lesion, we were not able to get into that. So finally, I took I think a Gaia third or something, which I could direct. You can see how the wire has gone. I was not sure whether this was in the vessel anatomy or it was outside. So there was a big struggle to actually get back into the true lumen. With multiple wires, probably we used about 14, 15 wires on that day. Then finally, I think it was Conquest Pro, which finally tracked into the true lumen at the proximal RCA. Once we were into the proximal RCA also, it was almost impossible to track the caravel catheter. So we had to use a trap balloon and trap the retrograde wire and then bring back, externalize it. And beyond that, it was a straightforward retrograde. You can see that there was probably a CTO segment here and a distally here. So, so I exchanged it for a Grand Slam wire, confirmed the collateral positions and stented the entire segment. So you can see that it came out quite well. Then at this point, it was already almost like 2 hours of this procedure. Ideally, I should have stopped here, but it was so tempting to do the left because I had opened the right. So I wired it again and just ballooned it with a small 2mm balloon. And there was a long lesion. Again, thought about it for some time. Then I decided to stent it, which was probably not a good idea. So I ballooned the segments and first deployed the proximal stent. Everything looked okay. So I was quite happy that got away with the thrombus and stented the distal part also. Then there it happened. You can see that thrombus, like a brick, it had prolapsed into the LED, almost occluding it completely. Fortunately, the RCA was open, so he didn't have any symptoms. There were no ECG changes, no chest pain. I tried to kind of balloon it a little bit with low pressures, hoping that it will go, but nothing changed. It just stayed there. You can see it oscillating in the RCA. And I think the thrombus was still stuck into the LCX with some tail. So it didn't prolapse at all beyond that point, but it occluded the lumen quite a bit. So I started him on GP2B3 inhibitors and low molecular heparin for 2-3 days continuously. And on the 4th day, we repeated the angiogram. RCA was flowing well. and the left LED thrombus had almost dissolved to a small spicule. I didn't touch anything after this, so I discharged him, and he is doing well. It's almost 6 months now. So the take-home message is when you have a single donor vessel, it's an extremely dangerous situation where you have to truly watch out on if anything is going to happen. And thrombus migration is a real problem in osteal lesions. So before you attempt a vessel with single donor vessel with a thrombus in the other vessel, make sure there is another artery flowing, supplying. And the thrombus eventually dissolves if there is some flow across the thrombus. And a totally occluded thrombus takes a long time to dissolve. Thank you. This is my case. It's open for discussion from the panelists and the chair people.
Yeah, Dr. Anand, this is you showed this thrombus right at the ostium of the circumflex, and you said the only vessel now which was making him survive was LED. Could you have actually done this 2v3 business and then taken him later instead of trying to go through a vessel which was making him survive?
No, initially I underestimated the thrombus burden, so I just started him on low molecular weight heparin. I didn't put him on because it was already like probably 72 hours of symptoms. So I thought it may be a little more organized and may not respond to GP2B3A. So I just put him on low molecular weight heparin. I tried to daughter with a new balloon, but that didn't establish any flow. So I just thought it might work. But after 3 days, there was nothing changed. So I didn't want to discharge him with that. So and I didn't expect the RCA to be so difficult because he was just 33 years old. And I thought it must be relatively simple retrograde. But re-entry into RCA guide was really difficult and it took a long time. But eventually I was able to do it. It was a good result.
Yeah, good result.
So Dr. Anand, yeah, so I kind of...
I cannot to understand you much better if I can get...
What I would like to comment is, obviously, technically, you did a procedure very well. So all taken retrograde and thing. But I think the timing of the procedure is up for debate here. If the patient presents with a acute coronary syndrome and that too kind of a late presentation of ST elevation MI, I think I would definitely not go with retrograde approach at all for this non-culprit vessel. At least 3 to 4 weeks time once we got the LV function done and things like that. Because the thing is, if you imagine the circumflex is beyond the 24-48 hour window, opening up of circumflex is just like a cosmetic procedure. We don't know what the LV function is like, and opening up of the RCA by a retrograde via the LAD is a very tricky situation. I would not even attempt antegrade on the RCA. Obviously, it needs to be done, but because here you could be in a situation that you have a major complication in the LAD, LCX is already blocked, and RCA is already blocked. The patient could have a major catastrophic hemodynamic compromise here. So I think, and obviously, being your experienced operator, you did it well, but I think in general, I think it should not be attempted within a setting of acute ST elevation MI. That's my comment.
Okay. Dr. Mehta, Dr. Prathap.
What Sudheer is actually mentioning is a very important point, basically because of the thrombus sitting in the circumflex ostium. Actually, that made Anand also making this case actually such a ACS with CTO in such a situation. It's a dilemma for the operator. That too, anesthetist brother sitting working in the same hospital. This patient coming collapsed with a thrombus migrated to LMCA. That will be a tough situation for Anand also, Sudheer. That is actually the one situation where you can anticipate, and he's losing a lot of LV function in the 2 weeks or 3 weeks time and getting a severe MR. Then what will be the situation? I'm just asking.
No, so I think that's what, so in terms of LV function, I think, yeah, it's a difficult problem, but if you attempt the circumflex before attempting the RCA CTO, how is it going to, I think the outcome would have been still the same. So you should have focused more on the circumflex before opening the RCA, because opening of the RCA is not help in the, it will not protect you from circumflex complication. And you see that OAT trial, which 24, 48 hours. I'm not saying the procedure was done well, you completely revascularize the patient in same sitting, but I think routinely, this is a high risk approach. I know that if a patient is a member of a staff and a relative of a staff family, and you rescued it very well. But if you had a major complication in the LAD before RCA is opened, that will be a catastrophic situation.
Yeah,
rather than having LAD open.
For attempting RCA was in anticipation of thrombus migration. Because patient was
but actually you got the same problem even after doing that.
Yeah. But I was quite calm because LAD had retrograde filling from the RCA.
I don't think that will save your purpose of central
I think it was done very well, no doubt about it. It's just like a general message that we always say you treat the non-culprit artery after some time, and that to a retrograde CTO. Obviously, if it's a straightforward antegrade, it will not put any risk on the contralateral artery. And I would just give him GP2B3A, and then I would have tried to attempt obviously aspiration, thrombus aspiration. And if the thrombus comes in the LAD, maybe I don't think RCA is protecting the LAD at all here. I don't think the RCA, opening of RCA will protect. If the LAD goes down, the patient will still be hemodynamic compromised. So I think the thrombus problem was still there. It's about how you manage a late presentation of thrombus lesion. So I think
it's a diagnostic dilemma, therapeutic dilemma for every operator. But I think this is very important. Actually.
Dr. Prathap, just 1 minute. Dr. Anand, very nice, might see done the procedure. But definitely, I will address the culprit vessel that is circumflex after 3 days. Once you have some dilemma and all these things, before attempting RCA. No doubt you did a very heroic and ultimately a good result came. But definitely culprit vessel has to be addressed first, as per the guidelines also.
Anand, this non-flow limiting thrombus in the LAD, which got migrated when you did the circ, I think time and again we have seen if it is not obstructing the flow altogether, just leave it off, and with drugs it should, when you restudy him, it will disappear. That's what we have seen.
Yeah. No, but the challenge was I did not know it will be a non-obstructive thrombus.
Yeah.
Migrated.
Another time. They're showing the hand.
Yeah. Okay, if there are no further comments, we can move on to the next speaker.
I think Dr. Bhamri has raised his hand. You want to make a brief comment, and then we move on.
Yeah, please.
Sir,
Yeah, go ahead.
Hello.
Yeah, go ahead.
So my question is, if after 3 days of GP2B3A, thrombus did not dissolve, then what will be your strategy? Stent the LAD?
No, I would have just left it for some more time, probably started him on rivaroxaban or something, or warfarin, and waited. Because stenting LAD was, I knew it was a thrombus. I know it's not a lesion. I know 100% the thrombus. So I would have still waited probably another 2 weeks.
Yeah, perfect. That's fine.
Anand, what was the LV function for this chap after some time?
At presentation, it was 45%.
No, but post, after opening up of the circumflex, and is that LV function improved, or is it?
It didn't change much.
You can go to the next case, actually, Anand.
Yeah. So the next case will be presented by Dr. Prasant Kumar, CHIP CTO. The right balloon makes the travel comfortable. Dr. Prasant, please take over the screen.
Is the screen visible?
Yes.
Very well. A lot of colors.
Good evening, esteemed panelists, and especially who is my teacher, in fact, during my DM days. Regards to you, sir. In fact, this is not an exotic case. This is basically because it was a translumina meet. They wanted me to present something on Nick Nano. Now, something very interesting is that I came through a quotation that when we have a CTO, we always say, God grant me the courage not to give up what I think is right, even though I think it is hopeless. So this is something, a 76 years old male. He was basically a Navy personnel, a diabetic, hypertensive, long-standing. He has a history suggestive of chronic stable angina for more than 5 to 6 years. Started having angina since 5 days. Troponins was raised. Just a sinus tachycardia on ECG. Reaches the emergency, has recurrent VT and defibrillated in emergency 4 times. And by the time we realize the patient is in cardiogenic shock, 60/40, his LV dysfunction, ejection fraction for 35% with the hypokinesia in the RC and LAD, he's on inotropes, intubated in the ER, shifted to the cath lab on CPR. The first thing that we do is put a temporary pacing and an intra-aortic balloon. So this was the ECG which he reached. Doesn't show anything very interesting to tell that he has a MI, but definitely it was an ACS situation, but he had a cardiac arrest. And this was the X-ray that was immediately done, which shows the patient was in acute pulmonary edema. This was a post-defibrillation ECG, which shows that there is some degree of this is LBP with the first degree AV block. Now, the first thing that was done was to put a temporary pacing because his rhythm was not very stable, put an intra-aortic balloon, and then this is the post-intra-aortic balloon pressure. So you can see the augmented is around 90. So the next thing was to just do an angio and have a discussion with the relatives, what is the problem. So the LAD looked pretty bad. There were multiple blocks. The circ was totally occluded. The RCA was totally occluded. And the patient was still having some angina and in fact is already intubated. So we were not sure what to do, whether to send it to the surgeon or we called the surgeon. The surgeons told that it is very difficult to graft this LAD and RC. We don't know whether there is really an artery which can be grafted. The circ is totally occluded. Chronic total occlusion looks like. We don't know the viability. So then we had to take the decision. And this is just the angio that I'm just showing the moving images, just to see what was the LAD, circ, and the RCA. You can see that almost all the three were almost totally or subtotally occluded. Now, what modality of revascularization can be suitable in this case? Now, I first thought I would cross the RCA and do a rotathectomy because, but I'm not sure about the distal vessel size. The burr could stuck, there could be perforation, I could go in a fall passage, patient CS, cardiogenic shock, there would be slow flow. Something struck me that could a Nick Nano hydro work. So first thing was to take a micro. Was it worth to try this lesion? Something very wiry and diffuse, but we don't know whether what is going to take place. So that is what the first that I did was take a microcatheter and taken this thing intermediate wire, and luckily it crossed. It didn't have much of difficulty. I could cross the lesion, but the problem was that even a 1 millimeter balloon wouldn't cross. It would get stuck over here. So that is the time when I thought that we take a Nick Nano, and the Nick Nano could easily cross the lesion. And this is what I saw after crossing the lesion and after having serial dilatation, I could get a very huge RCA. Definitely this was a dominant RCA. And this is what we see, that this was the multiple balloons that were used. A large dissection has been caused. And then a distal stent was put 2.5 into 30. DS, a proximal stent 3.5 into 48. And then all were post-dilated. And this was the final result. So what looked like a very small artery, when at the easiest way to do it was just to cross it with a balloon, a smallest balloon, a 0.8 size balloon, and the trick was done. And this was the pre and the post. Here you can see that hardly anything is seen. And with intra-aortic balloon support, the patient could be, somehow the patient started having blood pressure becoming stable. So the next thing that I thought would be that this should be a cakewalk to just do the LAD. But the problem was that the LAD also no stent, no balloon would cross. That is, this was possibly a very calcific lesion. In fact, in spite of being an avid user of imaging, I still then wanted to finish the case quickly. So that is why what I did, again, I took another Nick Nano, and then after multiple dilatation, put 2 stents, and the job was done and the patient was stable. So if you see the sets of balloons we have used, we all started with the Nick Nano of 0.85 into 6 for the right side, 0.85 into 10 for the left side. And then there are some around 15 balloons that were used finally to get results with around 4 stents. And finally, the patient did well, was extubated after 72 hours. But in the meantime, with that whatever amount of contrast we used, the patient needed one sitting of slit. The IIP was weaned off and was removed on day 4. The patient was discharged on day 8. 1 month follow-up, fully mobilized, renal function, the RCT, the LSER criteria on viability was not viable. So left it like that. Ejection fraction had improved from 35 to 48%, and the patient was doing well. So this Nic Nano, you know why the Nic Nano is a good balloon. I did not go through all this, but basically we know this is the smallest crossing profile balloon where there's the highest rated for burst pressure, and it is the best part is that it is a hydrophilic coated balloon and can be easily crossable for subtotal and total occlusions. So the learning points are that Nic Nano Hydro is suitable and safe for balloon uncrossable lesions, but the distal arch is not visible, and we sometimes may consider rotatherectomy unsafe. So I conclude by saying that there are not hopeless patients, folk have to be hopeless about them. Thank you very much for the patient hearing.
Thank you, Dr. Prasant. Wonderful case and challenging clinical situation. I would like the chairpersons to make some comments. Dr. Mehta.
Well, in between, I had lost the connectivity. Just wanted to know the intra-aortic balloon pump. Was there a pulmonary artery catheter also, or was it not there?
Yes, pulmonary artery catheterization was done, sir.
Right.
That is what you have been teaching us always.
Yeah, because in a situation like Sahoo, it was pleasure that you were with us in Sion Hospital for such a long time, and I visited your lab also. That was my pleasure. Maybe about 4 years ago, 5 years ago.
Yes, sir. Yes, sir.
I came to your lab. Okay, fine. So what I'm trying to say is that, yeah, because optimization of a filling pressure is very important in management of a cardiogenic shock. And, you know, intra-aortic balloon pump augments the cardiac output by only 0.5 to 1 liter. And that way it is not. But I don't agree that it is being painted very inferior to Impella and whatnot, and which I think I deny, because there are so many other advantages for with the intra-aortic balloon pump. Apart from its Venturi effect, which I think reduces the left ventricular stroke work, fills both the coronary arteries simultaneously, perfuses even the non-culprit arteries also. So intra-aortic balloon pump is handy. Cardio Impella would be needed when your blood pressure is less than 40 or there are severe arrhythmias. Then I think balloon pump will fail. What do you say, Prathap, Sudheer?
Your comments are the most valuable, sir.
Sudheer,
the Nic Nano balloon actually, well, it's a wonderful balloon. Actually, as PK Sahoo told, some of the situation, Nic Nano will help you in where we are actually afraid to take a rota. Actually, Nic Nano is a wonderful balloon. Actually, helped few occasions for me in real tough CTO where I thought I will be landing only with the rota, because that is actually, this is actually one case where he has shown it was easily crossed, even though he has taken another 10-15 balloons after that.
Prathap, in that situation, that I find that of late usage of tonus is very much reduced. I mean, in this kind of situation, if Nic Nano does not work, one could consider using a laser.
Only in available labs, sir. There are many people who cannot afford laser, and more it is not available in many places.
These are pragmatic problems, yes.
Yeah. Especially Mumbai like place or Delhi like place where the industry also will be willing to share a laser immediately to you. When we are stuck in a lab, nobody will come and help us, sir.
Okay.
Actually, Sudheer was making some comment. Sorry, Sudheer, I interrupted.
No. Yeah, it's a good comments. Yeah, I think the balloon pump is still quite important hemodynamic support during the procedure. And obviously, I know it's not as powerful as Impella. If the patient has got severely reduced cardiac output and severe LV impairment, then Impella might be required. But obviously, with the balloon pump is very useful in terms of to reduce complication during the procedure, peri-procedural it will bail you out of any ischemic complication when doing a PCI, such as what Dr. Sahoo has done, presenting with cardiogenic shock. This is one indication for opening up as many vessels as possible in one sitting. So he did a good job opening the LAD and the RCA, and the patient obviously did well. There was a trial which is done by British Cardiac Interventional Society, looking at the randomized trial to look at the role of balloon pump. Obviously, what it showed is that it did not affect or it did not reduce the mortality in the long term, but peri-procedural complications were significantly less with balloon pump, ischemic complication, and obviously it's like it's a good device.
Only point is actually, Sudheer, if at all you are using an IABP, you should use pre-procedure wise, not during, after the procedure. And that is actually major complication happens also.
I agree, yeah.
Yeah, I do find this data on intra-aortic balloon pump difficult to digest, because I think it will be impossible for most of us to operate without an intra-aortic balloon when we don't have an impel at hand. And I think each operator can swear that a number of cases that have been saved by an intra-aortic balloon. So I'm still struggling with the data that says that it doesn't improve mortality when it can improve the short-term outcomes. So can somebody throw some light on that?
See, I think patients, sorry, Anand, I think the patients who are presenting with cardiogenic shock, they are basically sick people, very, very sick people. And what I think ultimately decide is the eventual final ejection fraction with which the patient leaves the hospital. That I think is the most important thing. In that respect, if you ask me, even Impella also did not improve the mortality. It did not. So I think, but I totally agree with you. It makes the procedure somewhat comfortable in the cath lab. I mean,
and Anand, please go on because time.
Yeah.
Time is flying.
Yeah, so we'll move on to the next speaker, Dr. Ravi Gupta, on retrograde or antegrade. The show must go on. Dr. Ravi Gupta, please take over the screen.
Thank you, Dr. Anand. I've been seeing so many good cases, and this is my privilege to share a case. And actually, it's a continuation of what we have been talking. I hope my slides are visible.
Yeah.
And I'm audible? Yeah.
Yeah.
So this patient, which I'm going to discuss, is almost 80-year-old male. He came with heart failure and angina, and his drop was positive. He underwent an angiogram 13 years back, which was a clear-cut case for CABG, for which he declined. He didn't have that CD, no details were available, but he was diagnosed as triple vessel disease, and he declined CABG. So it took 2-3 days to settle him out of failure. And once he stabilized, he was in atrial fibrillation also. So with the injection amiodarone, we were able to revert his rhythm to sinus rhythm. His EF was around 30 to 35%. And once the patient was stabilized, we did his angio. So this was his angio. This is the right coronary artery. And this was the left system. You can see a very tight ostial LAD lesion. So we tried to convince him again for a CABG, but looking at his age, we were also somehow not very much convinced that how he will take CABG. He was very frail patient. So ultimately we decided to go ahead with an angioplasty and decided to fix the left main to LAD first. So this was the angioplasty which we did in Vivo ISAR stent. 4 into 32 stent was deployed. And you can see that now you can see the collaterals of the right coronary artery very nicely. So this is one which tempted us to plan a retrograde PTC of RCA in a staged manner. So while I was just thinking patient has around 35% ejection fraction, he was improving, he was discharged, and we planned to admit him again after 15 days or so. In between, we had a live case. So I thought that this must be a good case for live demonstration. So we planned it as a live case, and this was on 6th of April this year. And we had actually two cases planned. One was from our Sahoo branch, South Bombay branch, and another was from our North Bombay branch. So this is how we started. And we have two catheters in place. And in this view, you can make out that there are some good collateral channels coming from the left system to the right. And then we have to decide whether we should go antegrade or retrograde. So these retrograde channels were quite tempting. So we thought that we should start with a retrograde. And out of these two channels, you can see one septal is coming here, and it has a good connection with PLB. And there is another channel from the distal LED, which is coming and connecting PD. So out of these two channels, I chose the upper channel, this one. So this is how we started. We started with the filter XTR wire, and COSCR 150 was chosen. So this is how I entered in this collateral. And then after entering to some extent, we took out the wire and confirmed where exactly we are. And here you can see that there are two channels. Actually, this channel is bifurcating into two, and this is again becoming one. So I chose the lower one and advanced my wire further. And here my wire is going seamlessly, absolutely comfortable. So I am very sure that I am in the right coronary artery. Here, I am just trying to advance my wire and catheter very slowly, gently. And here my catheter goes here, and I took out the wire just to check that where exactly my wire is. I am sure that my wire in the distal part of RCA, but is it near the distal part of CTO also? This was the shot. So, I don't know whether I'm in a coronary sinus or I have gone subintimal, although my wire didn't give me any abnormal feeling. But this was the point when I'm very sure that I am in right coronary artery, but my distal end of the wire is not in the distal end of the CTO segment. So this is the time when we decided, okay, should we try antegrade now? So we left our microcatheter there only, and I started filter XT. Yeah, you can see that very slowly. There's a lot of bridging collaterals also, so we are going very slowly, checking in different views. And this is how, when my wire looped, so I was almost sure that I am in the right track, because now there is no, the feeling of the artery that I am in the right artery. Actually, this point, I thought that our job is majorly done, but actually the real struggle starts now. So what happened that after crossing this wire, as we saw Dr. Sahoo's case, there's a lot of difficulty after wiring, passing a balloon. And this is one situation when we all say that 99% success is actually unsuccess. So if you are crossing a wire in CTO, of course, the biggest challenge in crossing the wire, but rest all steps are also important. You can be stuck up at any point of time. And there was a pressure of live transmission. So my live transmission time was about to finish. And in between, we received a call from our Novo branch that their case has been cancelled because of some technical problem. And fortunately, I got some extra time. In between, I was trying almost everything which I could try to pass the balloon across it. We took a lot of numbers of wires, did all the techniques which we could do. We took a guideliner, but that guideliner also did not help us. We tried to anchor a side branch, but there was not a major side branch which could give us some anchor support, so we could take an extra guiding support. Another idea was to change a wire. This is again one thing which I cannot. My wire, this wire has given just a way, and that passage is so narrow that I can't pass another wire along with this. And when I'm not able to pass another wire across along with this, I need to use a microcatheter. and this microcatheter is also not going. So I am not able to advance the microcatheter beyond this point. Then we tried to slide another wire integrally. That also did not allow because the passage was very, very narrow. Fortunately, it just gave a passage for one wire. Another idea which came, which I gracefully disagree, that take out this wire and take rota wire. This idea I gracefully disagreed because my learning, of course, senior people are also here, they can guide me. But the principal learning says that once you have an access, don't lose that access. I mean, taking this wire out and then try to negotiate a rota wire, you may lose the access for forever. So I did not agree to this gracefully. So this is all we have been doing. So I am not having clips of all those. And a lot of balloons, including mini track, resin, and actually Nick Nano also. I mean, I was very hopeful that probably Nick Nano would help me. But with all due respect, this is a wonderful balloon, but in this particular case, it didn't help. So we were stuck, but we have some extra time. So Dr. Mehta was actually remember Tornus. So this is one case where we took Tornus. Tornus is a microcatheter where you actually go with a corkscrew movement, and you should be very careful that you should not cross, or the corkscrew should not be more than 20 times. I mean, if you are doing more than this, probably the Tornus can get stuck there. Then it would be a difficult thing. So with very slow corkscrew movements, we are gently releasing it, then again keeping a gentle pressure, again advancing the Tornus further. Now you can see the Tornus has advanced significantly, and we are trying to negotiate the Tornus. Then I took a 1.28 balloon, make some space there, and this is what we could see. We could see the whole artery, and it gave us some sigh of relief. And this is Tornus. Of course, all the senior people know about Tornus, so I'm not going to talk about this. But in a particular case, this is the one which helped us significantly. Then we took a 220 mini track balloon, initially with 1.28 mini track, then 220 mini track pre-dilatation was done. Then we exchanged the wire with a microcatheter to a safer wire. And after doing this, we did an OCT run, but unfortunately, I'm not carrying those OCT runs. And then with dilatation, we took a balloon. With OCT, we decided the distal zone, the landing zone, and the zone where we are going to end. So we started right from the ostium, and we made sure that we don't leave ostium. So in different views, primarily the caudal views, we decided to take 338 Giants expedition. And this was the stent placement. During the placing statement, I'm just taking out my catheter. And this was our final result. And then we did a post dilatation with a 315. I mean, after this, I did one OCT run also, which shown that there is some post dilatation is also required. So this is what we achieved at the end of the result. This is few happy paces, I mean, after a marathon case. And the take-home messages. This is very important. When we are planning to do a retrograde case, it is also always important that we should correct the donor artery first. I think this is very, very important. You should not touch a retrograde case or a artery which is having collateral from a disease artery. So in this case, we fix the left main to LAD first and then plan RCA. And fortunately, the patient's EF, which was 30-35%, came to 45 before starting the second procedure. So it gave us some strength, some confidence to the patient, the family also, and you are also more confident in taking this type of patient. Never remain stuck to one thought only. Always keep on thinking that if it doesn't work, what next you are required. Never lose the access. That is, I mean, this is my opinion. Please correct me if I'm wrong. And keep all your arms ready on shelf. I mean, in this case, if probably we had no Tornus on our shelf, probably we wouldn't have done this case successfully. As I said, that CTO 99% successful means unsuccessful, and we should use easier cases for live demonstration. Thank you very much for your patient listening.
Dr. Ravi, thank you for that lovely case. And your situation was a real nightmare for anybody to find your wire somewhere completely offline from where it should be. And I think you tackled it very boldly and in the right way with the right device and the right hardware. We would like to have some comments from the chair people. Dr. Duggal, we've not heard from you. Any comments, please?
Duggal sir, your mic is
muted, sir. Your mic is muted, sir.
Yeah, can you hear me now? Yeah.
Yes, sir. Yes, sir.
It's an excellent case, and
It's an excellent case and
very well done. But what probably I thought was, if you had an extra backup support in your right, you had a Judkin catheter throughout the procedure. An Amplatz would have been very helpful there, and you probably should have started antegrade first, then go retrograde. That is another thing which is different. So extra backup support, maybe an Amplatz, and start antegrade and then go retrograde rather than retrograde and then go antegrade. Though you can do that, you can switch over whenever it is there, but it is better to do antegrade first and then switch on to retrograde. And of course, dual approach is the last approach.
Yes, sir. Thank you.
Dr. Gnanaraj, Dr. Ravi, can I have some comments?
Yeah.
Yes, sir. Yes,
Can I have some comments?
Yeah, please, please.
As Dr. Duggal told, the first antegrade approach is important. Second important when approach number. Second one is Gnanaraj if one fails, then Tornus. Suppose if Tornus fails, definitely you can take the rota wire with the help of a coronal microcatheter, which can able to cross.
Kapardhi echoing.
Yeah, sorry. Actually, now it is okay.
Okay.
yes, sir.
Technical
Yes, sir.
stuff.
Now it's better. Now it's better.
So I think these three series, you can first increase the support by Amplatz or this guide extension. And already you did this side branch anchor and all these things. Next important is Gnanaraj. Suppose if it fails, then Tornus. If it fails, then you have to do rota with the help of the microcatheter exchange.
Actually, I just wanted to have two comments. One, Ravi, a wonderful case, no doubt. But actually, you made 2-3 comments. One, you told that your wire was retrograde wire was exactly in the right coronary artery. How do you confirm it? I don't understand that. Number one. Number two, if it was in the right coronary, you would have kept the wire there. When you went the antegrade wire, you should have shown that that wire was in the right coronary artery. It was definitely out of the vessel, no doubt about it. There are a lot of ways to go out of the vessel. We have done retrograde CTO when we are seeing the wires going somewhere and we are not seeing that. Number one. Number two, you told that my rule is actually not to leave the wire. Actually, if the Tornus failed, what would you have done? When Gnanaraj failed, your Tornus failed, what would you have done? And actually, that is one way you should understand that these are the ways. And we have, as Kapardhi told, we have seen places where Tornus failed many, many times, not once or twice, many times. And Tornus is one device. It can be a handy earlier time when we were actually not trying to do rota in a CTO segment. We were thinking that Tornus is the only way out. Now we understand that there are ways the microcatheter to be kept on the tip of the proximal cap and then put a rota wire and escaped. How many times we are escaped? So Gnanaraj is one way. You are lucky that your choice of that day, your lucky device was Tornus, but some days the same thing, Tornus fails, you may get into Gnanaraj or rota. So these all devices actually complementary. One day one will help, the other day the other one will help.
Yes. Yes.
Thank you, Dr. Prathap. I think we are running short of time. So we'll move to the next case, which is going to be presented by you, a double CTO. Please take over the screen. Yeah, we can see your screen.
Thank you. It is little interesting case. A 61-year-old obese man who is actually class 2 angina, admitted with a triple vessel disease with a double CTO, creatinine was 0.9. And my colleague has done PCI to OM on 5.4 and actually kept the case for me after 2 weeks. This was actually the OM lesion. RCA was, RPLB was occluded and not RCA total. And LED was occluded, you can see from the ostium. But he has actually done a stenting to the OM, 2.75 into 48 after pre-dilatation and post-dilatation done, and produced an extremely good result. My challenges in this case were, it was a double CTO, a CTO LAD and RPLB, an ambiguous proximal cap in the LAD, but anomalous origin of the right coronary artery from the left sinus. And the catheters, whether it is antegrade or retrograde, this was the challenges came to me. So a plan, actually, I just decided to put a JL catheter to cannulate the RCA because it was an anomalous origin. And you have 2 catheters to be kept almost side by side and keep it as a reference for antegrade. And if it's try retrograde to the left. I kept the JL catheter first and I did not take the dual injection because I could see everything to the one catheter. I was actually seeing a filter FC wire taken for the microcatheter alone. And I decided to take the wire. Wire was in another branch, which was not my choice of wire. So finally, the wire went into the branch which I wanted. I tried cyan black. Usually my wire of choice, actually, I just take a retrograde, actually, it's cyan black, not crossing Super 3 or X3R. Tried. Finally, I could find out the wire or the vessel where the wire should go. I just went into the collateral. I went into the proximal cap of the LED, which was actually cyan black. Then this is the time I should understand that what is the 7 French EBU 3.5 have taken. There is no osteoproximal disease, actually, LED is there, but it's an ambiguous cap. I took a filter FC with antegrade fine cross in the antegrade. I have a retrograde fine cross as well as an antegrade fine cross, but not able to cross. But you can see that the wire is actually going, making a bend in the distal part with the retrograde. The tried Gaia in the retrograde, not crossing, not able to cross even antegrade. The wire is actually taking a bend. I took an UB3 antegrade to understand, actually, I just don't know where to go and where to penetrate. And actually, I just took a UB3, actually Gaia 3 antegrade, then gone subintimal. After first UB3, then I took a Gaia 3 antegrade, went completely subintimal where somewhere. I saw that wire is actually somewhere. Then what I did is actually, I was actually having a microcatheter in the retrograde microcatheter. I took the Gaia's 3rd retrograde, keeping the antegrade wire in the proximal part and taking as the guide. And luckily, this wire actually found out the place into the proximal LED. You can see that wire is actually tracking into the proximal LED, and then it came into that. You know, there is a difficulty situation. 2 catheters are in the same sinus. I had a difficulty. I withdrawn the catheter and taken the wire inside. If you can watch in the left frame, you can see that actually I withdraw the catheter, making a way for the retrograde Gaia 3rd going into my catheter and keeping the wire outside. It went inside. So I thought actually my work is finished. No. Fine cross could not externalize. I tried rendezvous. This is actually rendezvous technique I just tried because I have an antegrade microcatheter, retrograde microcatheter, retrograde catheter down. I was thinking that into the antegrade micro, I will just take my retrograde wire, not going inside. Keeping the fine cross in the retrograde, then what I thought is actually fine cross with the filter FC antegrade. What I did is actually, I pushed the FC, pushed into the first septal artery. When I pushed into the first septal artery, I was actually taking a guide liner with that balloon, with a 1.5 millimeter balloon antegrade. So with that antegrade wire, this actually guide cell are taken in the antegrade catheter. The retrograde, actually the wire, the fine cross here. Then with that, I crossed into the guide cell. Then normally routine, once a fine cross crossed, RG3 wire, 1.5 millimeter balloon. We did IVUS to understand. I created some subintimal track. I did a 1.5 and 2.5 millimeter balloon dilatation. We did an IVUS to understand exactly what is the size of the vessel. We could see there is a 3.15 millimeter in the distal part and a 4 millimeter vessel in the proximal part. So the total vessel diameter was 4 and 3.5 from the proximal to distal. So we took a 3 into 38 stent, placed there. We did a 3.5 into 12 millimeter, 12 balloon post dilatation. We could see in well opposed stent, except in the middle part where there is actually some eccentric part, otherwise totally proximally good, and produced a result like this. Naturally, I will not stop here. I took a JL3 with a filled FC. There was actually a disease actually in the RPLB. I could see the origin of the lesion there. I tried with a wire. I just went. This is actually the wire with the Gaia third. But the Gaia third actually crossed in the proximal segment of the RPLB. But you can see that this wire is totally out of the vessel in the distal part. What I did is I withdrawn the wire. I tried, this is actually not the wire of choice. I took ultimate bro, taken a different angle to understand where exactly I am. The wire actually crossed nicely. Then it's a routine wire exchange of cyan black by balloon trap technique, 1.25, 1.5. We took a 2.25 into 28 distal, 2.75 into 15 proximal to the RPLB. Then we took a 3.5 into 18 proximal RCA. There was a tight disease. I thought everything is finished. When I took an injection, I can see the distal to the stent. My measurement was not correct. 3 into 12 stent and finished the procedure. Final angio shot is not taken with the stent. I just finished because actually I used a contrast of 475 ml. Nobody told me. I just gone and the procedure went up to 3.5 hours. 140 minutes of fluoro time, 17 gray was the radiation dose, and it is too much for a cardiologist like me. This is a rare case, a retrograde CTO down in a lady using a collateral from the anomalous right coronary artery, from the left sinus using a JL catheter and EBU catheter, a high dose of contrast, radiation, and fluoro time. That was the only negative point. And thank you very much.
Thank you, Dr. Prathap, for the very, very difficult case. I think it's a great challenge, and you've tackled it beautifully with all the available hardware and all the available skills that any ECU operator would have. I think this would have been an impossible case for almost most people I know. For want of time, can we just have one discussion and move on, because we are close to 8 o'clock.
I just a brief comment. It's a great case, Prathap. Just one question to you. When your antegrade Gaia wire went subintimal from the proximal LAD into the where your distal, where your retrograde microcatheter was at the distal cap. So that happens very many times. So instead of you trying to do the retrograde direct crossing, why did you not go for reverse card, dilate on the antegrade wire, take a soft wire from the retrograde where you were already there?
I was actually, Sudheer, this is the one question I came to my mind. I was actually, you can see that wire was totally out of the lumen distally, and it was actually 3-4 millimeters away from the vessel architecture. If I dilate and create a larger subintimal dissection and create a total septal flow losing, that was my tension there. If I create such a thing, I dissect from the osteoproximal part of the LAD, and there is a large septal was there, and the patient was surviving on a PDA as well as on an right coronary circumflex artery. So I don't want to lose the septal. Actually, the last thing I'll do in an intervention is actually losing the first septal artery. That was my tension there. Otherwise, as a routine practice, we do a reverse cut and then try to enter there and finish the procedure. So I was actually worried. My wire was distal, little more distally. If I had a segment of LAD, definitely I would have done a reverse cut and try to push the wire inside. What is the second question, Sudheer?
No, that was the only question. So that's a great answer. Okay, sometime we have to decide whether we want to do a retrograde wire crossing, true to true lumen, or we go for a reverse cart. Obviously, situation, different anatomical and angiographic situations will decide on a final strategy.
And Sudheer, actually, one more thing is actually, you know, that anomalous RCA with a JL catheter, there is a lot of difficulty, you know, just both the catheters are nearby. You have a lot of tensions, you know, a lot of tensions.
Okay, I think in the interest
Just
of time.
one comment, Prathap, did you take off after that 17 grade from the cath lab?
I did not, because I actually, that is a well question, you know. Very enthusiastic cardiologist, actually. I should not do that. I just actually given a message to the people that these type of procedures will land up in a lot of dosage of contrast. Otherwise, why I presented that?
Okay, thank you, Dr. Prathap. We'll move to the next presenter, Dr. Amjad Ali, to present his case on a OMCTO, the misleading road. Dr. Amjad?
Yes. Good evening, sir. Good evening, everybody. Am I visible?
Yes, you are.
Yeah. So my case is a simple but an interesting case of OMCTO with a multiple misleading road. So this is the brief clinical history of my case. He was a 61-year-old gentleman who had history of coronary artery disease around 2 years back with a documented lateral wall MI. He was on medical therapy for last 2 years with optimal medical therapy, but the angina was worsened for the last 3 months. So he presented to a center with worsening of angina. He was a known case of diabetic hypertension, and he had history of chronic smoking. His ECG was showing QS complexes in the 1 and AVL, suggesting old lateral wall MI with preserved left ventricular function. So we planned this patient for the coronary angiogram and revascularization. So this is the ECG of the patient at the time of presentation, which was showing QS complexes in the lead 1 and AVL with some ST depression in the lead V4 to V6. So we took this patient for the coronary angiogram. This is the right coronary artery, which was showing some mild plaquing in the proximal segment, PDS diffusely disease. On the right side, in the epicranial view, showing proximal plaquing in the LAD, and diagonal proximal mid-segment had plaquing, and diagonal was occluded, and the distal LAD was giving epicardial collateral to the large obtuse marginal branch. So these are the caudal view of the left coronary artery, which was showing significant stenosis in the proximal part of the LCX, and major OM getting supply from the epicardial collateral from the LAD. So it's a very large vessel which was occluded. So we thought that is the culprit vessel for which was causing angina. So we took this patient for the PTC of the major OM. So we tried to open the vessel with the pilot 150 wire, but it was going in the branch which was arising from the stump of the distal part of the LCX. We took another wire as a parallel wire support, but we are not able to find out the proximal cap of the CTO. So with the help of the microcatheter with a 150 pilot wire, finally I got the I am able to find the proximal cap. Here we can see the first I thought that cap was arising somewhere here at the origin of this fine branch, but actually it was coming above the this portion at the point of the trifurcation. This proximal cap was present. So this changed the strategy of my case. So first hand I thought it's a simple case from retrograde channel can be connected from the this distal this segment of the LCX, what actually it was connecting from the 10 mm above the this blunt head. So this CTO was having ambiguous cap, and the length of the CTO was also more than 20 mm. So which makes this simple CTO into a difficult CTO. But fortunately, with the help of a microcatheter and the pilot guide wire, pilot 150 guide wire, I am able to find out the I am able to puncture the proximal cap. And with some negotiation with the help of the microcatheter, I pushed this wire into the distal part of the obtuse marginal branch. But from this part of the segment, I was feeling some resistance to pass the wire. So what I did, I took the chip injection from the microcatheter, which confirmed my position of the wire and microcatheter in the true lumen. Then I exchanged my pilot wire with a run-through workhorse wire. And after exchanging the wire, I tried to pass the 2 by 10 mm balloon to predilate the proximal lesion, but it was not going. So I took 1.5 into 10 balloon to first predilate the proximal lesion on the LCX, and then I took the 2 mm balloon to predilate the proximal, and then finally the distal portion of the CTO. So after predilatation, this is the shoot which was showing dissection at the level of the CTO segment. So after properly predilating, I took a large 2.5 into 38 drug-eluting stent, which I deployed in nominal pressure at the distal part of the vessel. And after putting a stent in the distal part, I took another long stent, 2.75 into 48 drug-eluting stent, and deployed with some part overlapping part in the proximal LCX. So it covered both the proximal segment and the proximal part of the LCX and proximal segment of the CTO vessel. So after deploying both the stent, I serially post dilate the segment by 2.75 into 12 non-compliant balloon from distal to proximal with high pressure. So this is the final shoot after post dilating the vessel, which was showing good flow in the distal obtuse marginal branch. It was a very large vessel, and now it is also giving a collateral to the diagonal, which was also occluded. So this is the final shoot of my case. So in shortly, I can conclude that no CTO is simple. As I thought, this is a simple CTO, but the wire was going into the false track. So finding a true track and the puncturing the ambiguous proximal cap is very important. And in this case, if I'm not going to puncture the proximal cap, that the retrograde strategy can be a option, but that epicardial collaterals are very dangerous to negotiate, and it is better to avoid ad hoc CTO PCI, as I did in this case. Better to do angio and plan with team as a team. Better to consult with fellow cardiologists and examine the angiogram with different views and magnified views to find out the true channel and the collaterals, to look for the proper collaterals. And we need to prepare for change of the technique for retrograde both for CTO PCI, and always prepare to handle the complication. But fortunately, no complication happened and patient discharged asymptomatically. Thank you. So this is my short presentation of the CTO PCI.
Thank you, Dr. Amjad. That was a nice demonstration of how a channel should be picked, and how important it is to pick the right channel, and how important it is to go through the angiogram in detail and not just jump at it the moment you see it. Any comments, please?
Actually, Sudheer, what is your comment on the microcatheter injection?
Well, I don't advocate a microcatheter injection, and it was very close to the distal cap. If you are further beyond the distal cap, sometime you may do it, but I kind of never do it because it helps sometime, but majority of the time it causes problem, because if this is in the distal subintimal space, there are other ways to deal with it. You take the wire out and then you try to aspirate with a syringe, and if there's a free flow of blood coming, that gives you some indication that the distal tip is not in the subintimal space. But I try to avoid subintimal injection very close to the distal cap. But you did very well. I think multiple views are required to know where the proximal cap is, and this is one of the ambiguous cap. And once you are in the cap, then it looks like the tiny branch was coming out in between somewhere, which is not visible very well in the RAO caudal views. I'm aware of the time as well, and there are a few more speakers left. So I think.
Amjad, actually, it was a wonderful case. Only one point was actually there were multiple channels creating a problem for you, but this injection through the microcatheter which should not be a message to the participants. That is what I just wanted to tell.
Okay.
But you have to aspirate and see that the free flow of blood is coming. And free flow of blood, actually, aspiration is actually, there are some technique. Most of the people aspirate without even filling up the contrast there. That is why the blood is not coming up. That is actually one issue we should understand, how to aspirate properly. That is why lack of the time, we cannot discuss much on these things. Okay.
Thank you, Dr.
Thank you so much.
And thank you, Dr. Anand. We'll move on to the next session. Next talk by Dr. Ashish Singhal, when CTO behaves chaotic and troublesome occlusions.
My slide is good. Good to the presenter.
Yes.
Okay, so I'll straight away move to my case. It belonged to a 70-year-old male who had a complaint of exertion angina for past 4 months. He was a known case of COPD, had a history of infralateral MI, which was treated with a primary PCI 4 months back. CAG at the initial time showed a double vessel disease of left circumflex, culprit vessel, and RCA CTO. Vitals were within normal limit. ECG showed QS complexes into 3 AVF and LVF of 45%. Stress myocardial perfusion scan was done, which showed an partially viable RCA territory. So these were the angio shots. So we can see the L6 was normal with a patent stent with no significant lesion. RCA was a CTO filling retrogradely from left channels. But the problem is the RCA was originating abnormally from the left sinus posterior superiorly, no, anterior superiorly. So we decided to do first an antegrade attempt. We used a 7 French line femoral access, tried using a JR 3.5 and AL1, but it was not cannulating. And then we used a 6 French JL 3 guide for cannulating RCA. Initially started wiring RCA with the fielder X3, but we failed even with the balloon support. We used then Gaia 2. It went ahead somewhere down in the RCA. We were not sure whether it's correct or not. So we dilated with a 1.210 NC balloon, which is the smallest balloon available in the lab at that time. RCA opened up partially from the proximal part, and we realized that the wire was in the wrong track. After multiple attempts, we were able to pass the wire into the distal part of the RCA. And during the passage of the wire, we realized that some part of the wire was in the subintima, leading to the dissection. So we pre-dilated with a 1.5 into 8 NC balloon multiple times, opening up the RCA. And we then taken a check shot, realizing there was a massive dissection right from the proximal to the distal part of the RCA. And we changed the wire to the fielder XT, which was the initial wire we used during the case. So we started sealing of the dissection from the distal part of the RCA with a 2.528 des in the precrux part, followed by another 333 in the mid RCA. Another 3.544 stent was deployed in the proximal part of the RCA, all overlapping stents. Then we taken a check shot. We showed a residual dissection in the ostial part of the RCA. And we also realized there is some perforation occurred in the right posterolateral branch of the RCA. So at that time, we had some problems in our cath lab. We were not able to record CNA because of the overheat of the lab. And we deployed another 3.519 des in the ostial part of the RCA to cover the dissection, which was remaining. And the RCA perforation, which we visualized, was tackled by giving a prolonged balloon inflation of 1.58 into the proximal part. Over the time, the perforation decreased. Patient remained hemodynamically stable, and we did an echo, which showed no significant pericardial effusion. And this is the pre-final shot. We can see that there was some dissection left, but it is decreased. And we were again unable to record the final check shot, which showed that because of the heated lab, that the dissection, the perforation was nearly sealed off. So during this case, we have tackled multiple challenges, particularly the abnormal origin of RCA and a high JCTO score, along with a diffuse dissection in RCA and a perforation. And finally, the patient was discharged on post-operative day 3. And we were happy that the case went without much of a trouble. Thank you.
Yes, Dr. Singhal, a very interesting case, and you did very well. Some basic observations. I realized that you did this without any contralateral injection. So I think in today's age with CTO PCI, when you're using stiff wires, I would advocate you should always use bilateral angiography so that you know for sure where your wire is going. And sometimes if you dilate with the balloon without knowing where your wire is, it causes these problems. That wire might be outside the artery, might cause perforation. And another thing is when you keep taking, I would never take injections on the antegrade or the CTO vessel because that increases the dissection. So you have to confirm your wire by retrograde injection if there are collaterals available, but you rescued it well. So those are my observation. And I think in the interest of time, you might want to move to the next case. And then if there's any time left, we can have some discussion.
Point well noted, sir. Thank you.
Yeah, thank you, Dr. Sudheer. We'll move on to the last presenter, Dr. Chetan Swarup. Chronic total occlusion, every case is a new experience. Dr. Chetan, please take over.
Sorry, Dr. Anand. I'm Dr. S.S. Bansal. I'm
yes.
Yeah. So
we know you, Dr. Bansal. Yes, go ahead.
So good evening, Dr. Sudheer, Dr. Prathap, and Dr. Anand. And basically, Dr. Chetan was supposed to present this case on my behalf, but then I decided to do it myself. And are you able to see my screen?
Yes, yes, go ahead.
Okay. So my case basically is a double CTO case with the occluded bilateral femorals. So I did not have femoral access in this patient. And the gentleman was 62-year-old male with effort angina class 3. Because of the occluded common iliac vessels, he had intermittent claudication. Ejection fraction was 45%, but both circumflex and RCA territories which were occluded, but the territories were viable. The patient had CTO of proximal RCA and a long CTO of obtuse marginal 1. Because of the occluded femoral arteries, I chose radial route because that was the best bet. And then, of course, these are the hardwares which I used. I did not have to use too many wires. I used only 2 wires for finishing both the cases. And the support for radial Judkin right was not found to give me adequate support, but this is what was available at that time. AL1 with side hole was not there in the cath lab at that time. And we used these 2 guide wires, and I had to use Corsair as well as Crusade double lumen catheter to achieve that success. These 3 balloons were used. And these were the stents which were used. Now you can see that femoral access was not available. Then I shifted to the radial route. I tried initially to cross with the Judkin right catheter. Bridging collaterals are there. The segment is not very long. Maybe it was 15 millimeter long. But the entry point was not clear, and there were 2 branches coming at the site of occlusion. So every time the wire was going into the branch and the blunt proximal cap was there, and I was not getting good support, but luckily I had a very good conal branch. So I parked anchoring balloon in the conal branch with 2.5 into 15 millimeter conal balloon in the conal branch for anchoring, for getting a stable guide support. Then I took the Corsair. With the help of Corsair, I could pass this Gaia 2 wire. This Gaia 2 was going into the branch at the level of distal cap, but after redirecting it, I could enter and then change it with a. I ultimately changed it with a Sion blue wire. Then the things were much easier after this, and I could then place a stent without any problem. So this was my final result. Then because this patient had a absolutely normal healthy LED artery, I did not want to send this patient for surgery. But this lesion was more complex because it also had bridging collaterals, and the length of the lesion was more than 2 centimeters. And also the entry point was quite ambiguous. With the help of Corsair, I was trying to enter, but I was not getting into the true lumen. Initially, I took a Gaia 2 wire again, but this Gaia 2 wire was, in this view, you can see very clearly that this was not in true lumen, it was in false lumen. I then took a double lumen catheter Crusade, and through Crusade, I tried to enter into, I used a parallel wire technique with the help of Crusade and used another Gaia 2 wire. And ultimately, I could, with the help of Crusade catheter, I could redirect my Gaia 2 wire into the true lumen. The first wire was in the false lumen, second from the second lumen was in the true lumen. Then the things were much easier. I exchanged it. I took a Sion blue wire again. This was a Sion blue wire, not a feeder XT one. And this Sion blue wire could be passed through the double lumen catheter without any problem. The entry point you can see was not very clear, proximal cap, and then the things were much easier. And of course, I took a long stent of 48 millimeter because some dissection was there in the middle portion. I covered the dissection. 3 into 48 millimeter stent was 2.7 into 48 stent was taken, and we got this was a Vivo Izar stent, and this was the final outcome in this patient. Here, the take-home message from my side is when femoral route is not available, PTCA through radial route for double CTO is feasible. Anchoring balloon provides good support from radial route, which is required many times, especially while using Judkin right guide. Success in such cases can be achieved if we follow standard principles of CTO angioplasty, like use of microcatheters and proper planning beforehand. You have to see the lesion properly on angio, plan the things, and then go ahead. Stepwise escalation of wires, small curve at the tip of the wire, and use of double lumen catheter whenever required for exchange of wires and for re-entry after the dissection. Thank you very much.
Thank you, Dr. Bansal, for the lovely presentation and a very challenging access because when femorals are occluded, it is a one step back for any operator, and you clearly demonstrated the challenge.
Just a small question for Dr. Bansal. Great case, double CTO done radially. Congratulations. Could I just ask, what size guide catheter did you use radially? 6 French, 7 French?
This was 6 French. In both the cases of on right side, I used Judkin right 3.5 into 6 French. And on the other side, it was 6 French.
And did you have any difficulty in exchanging the double lumen catheter with 6 French? Once you had the second wire, maybe there might be some.
There was no difficulty in using the Crusade in 6 French catheter. I routinely use 6 French Crusade from 6 French catheter.
So how do you exchange how do you take the double lumen catheter out with the guide wire extension or
double lumen catheter we take out with the help of extension wire. If it is new, then you can use this inflation device also if it is new one. But old one, you have to, extension wire is the best for taking them out. Of course, trap balloon, you can withdraw it and trap the wire and then pull it out. That also is another way.
Yeah, that might be sometimes difficult with 6 French, the trapping, but
this is what actually, Sudheer, I wanted to tell that when you use a trap balloon with a Crusade 2 wires inside, actually you can use maximum and 1.5 millimeter balloon. Cannot be used beyond that. Otherwise, you'll be in real trouble. The wire get entangled and everything will be a mess.
Yeah, agreed. From 7 French, all these things are easy, but from French.
Yeah, that is why Dr. Bansal, we are actually telling that better to use a 7 French, even through radial. Actually, you have slender sheet available for a 7 French, because that will make your life easier.
Yes.
multiple devices going inside. That is problem, otherwise.
I agree, Dr. Gupta.
Yeah.
So you've got this 7 French slender sheath available. We have recently published a paper from multi-center European centers looking at randomized between femoral and radial 7 French or above catheters. And we had a good success rate. So a slender 7 French sheath can be put, and 7 French guide catheter is easily taken up in the radial artery. So slender 7 French is just like a standard 6 French sheath. Yes. It's got a thin wall.
Actually, what is my problem, Sudheer? When I take a radial, even 7 French, I will be my bending of the back and all. I just have a real tension for a long time. Long procedure is actually a real tough job. Anyway, the people who are used to do these things, okay, but the back will be a real problem.
So
okay, I think we had a great session.
Yeah, I think we've come to the end of the session, and we've had some wonderful presentations and some really meaningful discussions from all the panel. I thank all the chair people and the panelists and the presenters for sparing their time and giving this academic feast to everybody. And I also thank Translumina for the lovely organization. And thank you, everybody.
Lovely evening without a dinner.
I know.
Yeah. Virtual dinner.
And of course, dinner plus,
Thank
drink.
you all. Thank you, Dr. Duggal, Dr. Kumar, Dr. Anand, everyone, panel, Dr. Thank you, everyone.
Thank you, everybody.
Thank you very much, everybody.
Good night. Good night.
We met in Paris. Dr. Duggal and me were there in Paris long back. So after that, after so many years, I'm seeing him on the screen today.
Hopefully next Europe is here, sir.
Yeah, thank you.
Thank you so much, everybody, for joining. Thank you.
Yeah.